muscle. Now in your cat, it looks like a triangular muscle. And it's fused into that tendon, this tensor fascia muscle here. And it doesn't go very far. The color on the muscle runs out quickly. And then the rest of the muscle here, this tensor muscle, becomes this thick band that we call the IT band that extends down here, as you can see, across, it crosses over the lateral epicondyle of the femur and attaches to the tibia on the lateral side. So this action is showing you, this joint action here is showing you the friction of the iliotibial tract on the lateral femoral epicondyle as a fascial tract glides backwards and forwards with flexion extension of the knee. This area right here becomes a problem for long distance runners because there's no protection for it. It's a very interesting piece of anatomy, this IT band, extension of the tensor muscle here. The textbook will say the tensor fuses into the IT band, which really means the IT band is the tendon of the tensor. So this tendon extends all the way down here, and the gluteus maximus fuses into it as well. So this is a big problem for runners. This band right here, the IT band, causes massive pain in their knee, and the only way to fix it is to stop running. They have to just stop and let it rest, because once the inflammation starts, it's very difficult to get it to stop. Okay, so that's an interesting part of anatomy. The medius, which is just deep to it, to the maximus, this one attaches to the gluteal tuberosity also. So it's attached on the femur as well as the IT tract, IT band. The medius goes from the ilium, it's smaller, just from the ilium, over to the greater trochanter. So it's a little different attachment. It's a little more lateral attachment there and a little more superior, right? So the gluteus maximus comes down here. It comes down here to the femur. It goes further down. It hits the IT band, goes deep to the tensor, and sits on the bone. The medius, which is deeper, doesn't extend all the way down to the coccyx and the sacrum, which the maximus does, and it comes across and hits the greater trochanter. It's a smaller muscle. This one gets the superior, that one gets inferior. This one also gets superior gluteal, and this one goes from the ilium to the greater trochanter as well. Students see this and they go, hey, how am I supposed to know in a dissection of a cadaver the difference between the gluteus medius and the gluteus minimus? Because their attachments are the same. How would I know which one is which? Okay, that's it. The minimus is deep to the medius, and it is smaller. So you could tell these three from each other by way of their attachments. The gluteus maximus, medius, and minimus. All right, let's go around to the back of the leg now and talk about the tibial and fibular stuff on the back of the leg. So here's what I'm about to show you. This figure says the tibial nerve is responsible for bringing motor information to the hamstrings. So on the front of my leg, I learned 4 muscles. We call them the quadriceps. On the back of my leg, I'm going to learn 4 muscles, and I'm going to call them the hamstrings. On the front of my leg, see if this helps you remember. It helps me. On the front of my leg, I have 4 big muscles that attach to the tibial tuberosity. Only one of them goes to the hip, to the anterior inferior iliac spine. It's the big one right in the middle. The one on the outside and the one on the inside both go to the linea aspera and down. And the one deep just sits on the front of the femur, the lateral side of it. Only one goes to the hip. They all get the femoral nerve. On the back of my leg, I have 4 large muscles. 3 of them go all the way to the hip. See the difference? 3 of them on the front don't go to the hip. On the back, 3 of the 4 do go to the hip, and they all go to the same place. The only one of the hamstrings that does not go to the hip is going to be the short head of the bicep. Okay? So the innervations kind of sing that same song on the back. The motor information to the hamstrings is all tibial. So I told you this a minute ago. If you think about the back of your leg, the first thing you want to say is sciatic, but you want to do better than that. Because if you're going to do flexion at the knee, you're going to use the hamstrings. And you're going to use the tibial nerve to do that. Flexion is tibial, primarily. Because only the short head of the bicep, only the one that doesn't go all the way to the ischial tuberosity, does not get tibial. It, in fact, gets fibular. All right. I'm going to say all of these as we're going. All right, so here they are. Here's the bicep femoris, the long and short head. The long head of the bicep femoris attaches to the ischial tuberosity. The semitendinosus, which is the medial shallow hamstring, goes to the ischial tuberosity. And the semimembranosus, the deep muscle on the medial side, is the ischial tuberosity. So the long head, the semitendinosus, and the semimembranosus, all three of them go all the way up to the ischial tuberosity. Now, the long head here passes over to the head of the fibula and the lateral condyle of the tibia. That makes good sense. So if you remember, watch this. If you remember the quadriceps by name, you got them. Where's the vastus lateralis? It's lateral. It's out on the greater trochanter. It's on the linea aspera. It's going down to the tibial tuberosity. No problem remembering their name. How are you going to remember here? On the hamstrings, you want to put the biceps on the lateral side. The tendinosus and membranosus on the medial side. And that works in the cat too. Same arrangement. So the short head stops at the linea aspera. Now let's talk about that for just a minute. The linea aspera has the adductors attached to it. So I can pull on the linea aspera and adduct the leg. The linea aspera has the quadriceps attached to it. So I can extend at the knee from the linea aspera. And the linea aspera has hamstring on it. The linea aspera has the short head of the bicep femoris on it. So I can also flex at the knee. So muscles attached to the linea aspera can adduct the leg, they can extend at the knee, and they can flex at the knee. So to say it's an important spot, my goodness, you've understated that. The semitendinosus now, we're going to the medial side, goes to the ischial tuberosity there, and the semimembranosus, so that one, and the semimembranosus, ischial tuberosity, also to the medial condyle of the tibia. Now watch this one. The semimembranosus attaches to the medial condyle of the tibia. Okay, it's medial. Got it? Just like the tendinosus. But it also attaches to the lateral condyle of the femur. Now, if I'm sitting on the medial condyle of the tibia, and I want to drive to the lateral condyle of the femur, which way will I go? In anatomy terms, if I'm sitting on the medial condyle of the tibia and I want to go to the lateral condyle of the femur, which way will I go? Lateral and superior. What joint cavity will I pass across in doing that? An anatomy term that we learned for the back of the knee. What was the term we used for the back of the knee? The popliteal fossa, exactly. So, as the medial condyle to lateral condyle attachment here of the semimembranosus goes, we label then, by doing that, the oblique popliteal ligament. What is the tendinous sheet called on the back of the knee? The oblique popliteal ligament. what in fact is the oblique popliteal ligament? It is the fusion of the tendinous material of the semimembranosus. That's what's on the back of your knee. So when I say the semimembranosus is a larger, deeper muscle, this is what you should think. The larger muscle, deeper, attaches all the way across the back of the knee. Okay, that's the hamstrings. Now, last piece here, then we're going to tear the knee apart. This muscle, this popliteus muscle, you were not asked to label it on your cat, which is fine. But I don't like to go into the knee without mentioning it. Okay, so everybody thinks the knee is a hinge joint, and that is true. Your knee is a hinge joint. The knee itself the knee hinge joint will extend because of quadricep, and it will flex because of hamstring. This is what it does. Okay, but the truth is we can do more with our knee, and the truth is even the normal action of your knee is more than that. So what actually happens whenever you extend at the knee to stand up, when the tibia and fibula, when the femur and the tibia go vertical with each other, what actually happens is as the condylar surfaces hinge like this, you don't get a natural hinging like you would think in a regular hinge joint. Instead, what happens is, as you extend the knee, the lateral condyle stops first. And then, as you lock your knee, the femur rotates medially. So, as this thing rotates, this femur rotates medially, you lock and rotate the femur into place. And that is different than just hinging this thing. The reason I bring it up is because after we're standing with locked knees for a while, in order to unlock the knee, you've actually got to rotate the femur first. And the muscle that unlocks your knee so that you can flex is this one, the popliteus, that extends from the lateral condyle over to the proximal tibia. Okay, that's what I wanted to say there. It didn't come out beautifully, but there it is, the popliteus muscle. It unlocks by rotating the femur laterally. Okay. The knee. On the front of your knee is a tendinous sheet of material that pieces and parts have names. You won't have trouble remembering these. The tendinous sheet of the vastus medialis is called the medial patellar retinaculum. The tendinous sheet of the vis vastus lateralis is the lateral patellar retinaculum. The the tendon of these muscles, as you can see, fuses into the patella, along with the rectus femoris and the vastus intermedius, all to fuse onto this patellar bone. But that's not how these quadricep muscles work, because what we really know is all these tendons fuse together to form and fuse into what's known as the patellar ligament. And so I've cut it. It's been cut here so you can see it extending across the top of the patella. The patellar ligament, y'all, is really the tendon of the quadricep. That's really what it is, to do extension of the knee. Now, the back of the knee, as you can see here, the popliteal fossa, is covered with tendinous ligamentous material, and we call them ligaments, the popliteal ligaments. So you can see the big broad one here across the back of the knee is called the oblique popliteal ligament. But a good student knows now what that tendinous ligamentous stuff is really. So this oblique popliteal ligament is actually the fusion of what muscle on the back of your knee? This is the tendon of the semimembranosus, extending from the lateral condyle of the femur down to the medial condyle of the tibia. The oblique popliteal ligament is the big one on the back of the knee. Now you can see the popliteus here, which I just showed you, and its relationship to that ligament. And you can see here, which are not labeled, which I'm going to teach you momentarily. These are the attachments of the heads of the gastrocnemius. So that is the medial head of the gastrocnemius. That's the lateral head of the gastrocnemius right there. All right, now here's what it looks like on the inside. So I tear the knee apart to look at it inside, take all the muscles off, and this is what you discover. There are, in fact, 4 large ligaments that help hold the knee in place. 2 of them sit outside the joint capsule, and 2 of them sit inside the joint capsule. For that reason, these on the outside are called extracapsular ligaments. They're easier to get to, and you don't have to cut into the joint cavity to get to them. And the cruciate ligaments on the inside are called intracapsular. So 2 on the outside of the capsule, 2 on the inside of the capsule. Now, this one on the lateral side is called the lateral collateral, LCL, or the fibular collateral. And as you can see, it goes from the lateral epicondyle of the femur down to the head of the fibula. The fibular collateral ligament is the lateral collateral ligament. It's extracapsular. Now, what does it prevent? What does the fibular collateral ligament prevent from happening? It keeps the femur from moving lateral. You see that? So the femur will not move lateral off its condylar surfaces because of this ligament. So a blow to the medial side of the leg, pushing the femur laterally, is going to damage the lateral collateral ligament. The medial collateral ligament attaches to the medial epicondyle here and down on the proximal tibia. It's also called the tibial collateral. Most people call this one the MCL, the medial collateral ligament. This one prevents the medial movement of the femur condyles on the head of the tibia. So a blow from the lateral side this way on the knee will cause damage to the medial collateral ligament. Now the 2 intracapsular ligaments that sit inside the knee joint are called cruciate ligaments because they cross. And they're named, these crossing ligaments are named because of their tibial attachment. So both of them attach to the tibia. And learning their tibial attachment will help you remember their names, but will not help you remember where they go. So the anterior cruciate ligament attaches to the anterior intercondylar eminence of the tibia, and the posterior cruciate ligament attaches to the posterior intercondylar eminence. Now, the anterior cruciate ligament attaches to the lateral condyle, and the posterior cruciate ligament attaches to the medial condyle of the femur. So I don't know how to teach you a trick to remember that. That's something you have to just memorize. The name is the tibial attachment. Anterior cruciate, posterior cruciate. That is your tibial attachment. Its attachment on the femur, you have to just remember. So the anterior cruciate then crosses over inside the intercondylar fossa to attach to the lateral condyle. All right, let's do this then. What does the anterior cruciate ligament prevent? I know what the LCL and the MCL prevent. What does the ACL prevent? What is it? So it crosses from the front to the back of the knee. It crosses from the front this way, from the front of the thing, to the back. And does it go that way, or does it go that way? So there's the ACL right there. So the ACL is on the front of my tibia, and which way does it go? That way or that way? So that's the fibula right there. Does that help?
Yeah.
Which way is it going? It goes that way, it goes lateral, exactly. Okay, so it goes from the front here to the back here. So what does that ligament do when my leg does this? Is it getting loose or tight? It'd be nice if I had a knee model in here to show you, huh?
It's tighter?
No. No, so the anterior is actually moving toward the posterior, right? The front is moving toward the back when I flex, yes? The front of my tibia is moving toward the back. The ACL goes loose on this one. So when my knee is straight, it's extended like this, the ACL is tight. So how would I make it tighter? By pushing the knee that way. Do you see that? So a blow to the front of the knee, pushing the knee into its hyperextended position, damages the ACL, the anterior cruciate ligament. It goes from the front to the back, like this, pointing lateral. So you've seen this, right? I know you've seen it. I know you guys have seen it. He was hit on the tackle from the front and hyperextended his knee. So he's getting a lot of pain, so they carry him off to the sideline, right? And they put him on the table, yeah? And they get the weight off of his leg. And now what does the orthopedic guy do? Have y'all seen this? Yeah. They take the tibia now. They take the tibia and they move it. Now, which way will the tibia, so according to this ligament right here, which way should it not go?
It shouldn't go straight.
Okay, so it goes from the front to the back, yes? So you should not be able to pull the tibia forward. That should not happen with that ligament in place. So with the weight taken off the leg, if you can move the tibia forward, and anybody who's ever done it can feel it immediately, then you know that the anterior cruciate ligament has been torn. Have y'all seen this done on the field before? Do y'all watch these things? I mean, are you interested in the injuries of your friends? I mean, come on. So that's what they do. It's a real easy test. You just get the weight off. And if you can pull the tibia forward, you can feel it. The ACL is gone. Season's over, right? When that happens. And then, when they do the surgery, they take a drill. They borrow a tendon maybe from the biceps femoris, one of the hamstrings, or they get a cadaver tendon, and then they drill a hole underneath the medial side of the condyle of the tibia. And they drill it up through this way into the joint cavity. And they drill another hole across the top of the lateral side of the femur. And they run that tendon all the way through that joint cavity like this. Does that mimic the ACL? Yeah. And then they staple it on either side of the bones here. So they don't try to glue it to the anterior intercondylar eminence like the original, right? That's the original. They actually drill holes there. All right, and the last thing, do the PCL. The posterior cruciate ligament then, as you can see here, attaches to the posterior intercondylar eminence, comes through and goes which way? Lateral or medial? It goes medial, okay? So now, how do you make the posterior cruciate ligament tight? Yeah. So see, I'm moving that. This posterior cruciate ligament now is attached on the back of the tibia, and it is attached to the front of the medial condyle of the femur. So whenever you move your knee this way, that ligament goes tight. So you damage the posterior cruciate ligament by overflexion of the knee joint. That's the way you damage that. All right, now there is a transverse ligament shown here that attaches also out here. This particular text doesn't have it attached to the meniscus, but I never teach the details. There's normally, well, a lot of people have 3 or 4 of these in their knees, and they're not important, as far as I know, for much. And about half the population has variability on their attachment, so we're not going to mess with it. Gray's Anatomy has it attached out here to the lateral meniscus over to the medial, and so we're not going to worry about it, the transverse ligament there. But I would like for you to know about the menisci. These are fibrocartilage pads that sit in the knee joint, and they are C-shaped. They are thick around the back and the sides and the front. And inside the capsule, they're thin. So the meniscus shape actually contributes to the stability of the joint. So if you damage an LCL or an MCL, or even a cruciate ligament, a lot of times when you damage one of these, you have moved the head of the femur off of the condyles of the tibia. Sorry, you've moved the condylar surfaces of the femur off the condylar surfaces of the tibia with the injury. And if you do that, there's just no way that you haven't damaged the cartilage. And so the menisci actually form a little pocket almost that the condyles sit in so that they can't move front or back or side to side. C-shaped fibrocartilage pads. Now, the ligaments are vascularized, but the cartilage is not. And so ligaments, sometimes ligaments can be stretched or partially torn and they'll heal. But if you knock a piece of cartilage loose in the knee joint, eventually you're probably going to have something done to it. It's not going to heal. And so you're going to have somebody go in there with an instrument and do something, get it out, cut it, or whatever. All right, so a reminder of the tibia and fibula. And please review the names of the bones of the feet, the calcaneus and the talus navicular, the cuneiform. From a superior view, we also pick up the cuboid on the lateral side. Y'all learned all these in the laboratory. And so the last thing that I have to do with you, and I can't do it in 2 minutes, I need about 10. The last thing I have to do with you is to help you learn the muscles here, the flexors and extensors below the knee. So I've made my way down the leg to the knee, and all I have left is this part right here. So I will do that in the first 10 minutes of class on Monday, and the rest of the class period will be open for you to ask questions. So you'll have at least 40 minutes on Monday to ask questions about your test on Wednesday. All right. Some of you are asking these questions already, and you guys are going to be studying over the break, right? Okay, so you're asking these questions, and so let me point these out to you. I do not like the idea that students would memorize something